and welcome. My name is Susan Cohen, and I serve as the Assistant Vice Chancellor of Alumni Relations at Washington University. On behalf of the Alumni Association, it is my pleasure to welcome you to this edition of Wednesdays with WashU. We're very excited to sponsor this program today with the Brown School. I know most likely you have participated in numerous webinars over the past 9 months, but for those of you who are new to these events, I'd like to quickly review our format. You'll only hear and see me and our presenters. Feel free to use the chat function to introduce yourself. When you do chat, please make sure you select all panelists and attendees so everyone can see your message. We hope we'll have time for questions at the end of the panel. Please feel free to submit questions at any time using the Q&A button. The webinar is being recorded, and we'll also share it on the Alumni Association YouTube channel following the event. I would now like to ask Chancellor Martin to say a few words.
Thank you, Susan, and hello, everybody. It is my real pleasure to introduce to you all Tom Hillman. Tom is managing partner of the Lewis and Clark family of companies, and his ties to Washington University run deep. A 1978 graduate of the College of Arts and Sciences, Tom showed an early proclivity towards entrepreneurship, opening a cheese importing business in the Del Mar Loop while still an undergraduate. His wife, Jennifer, is a 1979 graduate of what we now call the Sam Fox School, and together they continue to make outstanding investments in Washington University through their personal philanthropy and as inveterate volunteers. Tom serves on the Washington University Board of Trustees, a role he first assumed in 2011, and currently chairs the Brown School National Council and sits on the National Council of the Scandalera Center for Interdisciplinary Innovation and Entrepreneurship. Jennifer holds 2 National Council positions as well, serving both the Brown School and the National Council for Student Affairs. In these roles, the Hillmans offer guidance and wise counsel to deans and university leaders. During the Leading Together campaign, Jennifer and Tom Hillman made a historic commitment to the Brown School that resulted in the naming of Hillman Hall in their honor. This year, we celebrate the 5th anniversary of the dedication of Hillman Hall, a landmark of the Danforth campus that fosters innovation and collaboration in social work, public health, and social policy. From the very beginning, Jennifer and Tom made it clear that theirs was an investment in the people of the Brown School rather than bricks and mortar. 5 years in, I think we can safely say that their philanthropy has elevated research and teaching in the 3 critical disciplines of the Brown School. Tom, thank you for taking your time out of your schedule today to lead the conversation about social determinants of health, an issue that lies at the intersection of social work, public health, and social policy. We are grateful for all that you and Jennifer do for the university, and we look forward to today's discussion.
Thank you, Chancellor Martin. I recall in your inauguration a profound statement, which was not Washington University of St. Louis, but Washington University for St. Louis. I hope that you find today's event to support that forward philosophy that you shared on your first official role coming to the university. On behalf of myself and my wife, Jennifer, we are thrilled to be part of the conversation with 3 outstanding members of the Brown School faculty representing Washington University and the BJC HealthCare system. I know that our audience includes alumni and friends from all areas of Washington University. In the next 50 minutes, we will highlight some of the work at the Brown School in particular. For those of you who are not as familiar with the Brown School, I thought it would be helpful to share a 2-minute video about the school to help set the stage for our conversations.
Across my career, I have admired the Brown School. It's a place where you can do your best work, driving evidence-based practice and changing this region and the world.
I don't think that there's been a more important time for institutions like the Brown School to be engaged in the type of work that we're doing.
And what we are trying to do is to come up with cutting-edge solution, new science, implement that in the real-world setting and find out what is working and take it to the scale and reach millions of households and improve their life.
Being a disparities researcher, I always joke with people and say that ultimately I like to be put out of business. I would love to not have to study disparities anymore. So that's the end goal, was to reduce and ultimately eliminate racial disparities in health.
One of the strengths of being here at the Brown School is the emphasis on intervention and turning our research into practice or policy.
You're seeing a school that's making a commitment to the idea of impact. And that impact in terms of impact factors, other metrics that we said we're doing well as scholars, but really trying to think about impact in terms of community and just growing into the ability to be willing to test itself.
Now we have to keep the pressure on ourselves and make sure that all of that discourse leads to real change. And that's why applied research, really putting students in the trenches and faculty, we need to stay engaged, but making sure that the people who need that information have it.
There's a lot of talk these days about the end of truth, and we don't believe that here at the Brown School. There are things that are true. There are things that are worth fighting for and worth doing. And we're committed to using the best available information, the best available evidence to try and make people's lives better. And I think that's needed now more than ever.
Our goal today is to highlight the work of our faculty as it relates to health disparities and social determinants of health. We hope that you will come away informed and excited about the innovative efforts of the Brown School, and also inspired to engage as members of your own community to help close the gaps related to health equity. As we all know, during this pandemic, it really has put a spotlight on the issues of disparities in our communities and across the country. With that, we have an outstanding faculty who are engaged in making a big difference, and I'm thrilled to welcome three of our outstanding panelists who are scholars in their own right. First is Mary McKay. She's the Neidorff Family and Centene Corporation Dean of the Brown School. She is leading a research on the topic of mental health and health prevention needs of youth and families impacted by poverty. Another panelist we have is Matt Kreuter, who is the Eugene S. and Constant Kahn Family Professor of Public Health at the Brown School and Director of Health Communication Research Lab. During the COVID-19 pandemic, the lab's Focus 19 initiative has generated over 100 reports on the state of emergency social needs across the United States. Our final panelist, Jason Purnell, is Vice President of Community Health Improvement for BJC HealthCare, a member of the Brown School faculty for over a decade. He retains an appointment as Associate Professor. Jason is also the founding director of Health Equity Works, formerly For the Sake of All. Our invitation today that everyone saw described our event, leading with the question, how does who I am and where I live affect my health? So I'm going to start with Jason, and what we'll do as a format is I'm going to call on the three panelists at different times, but the panelists will answer, and then if the others want to add on to the conversation, they'll do that. And at the end, we have some questions that have been presented that we'll read, and if people have questions along the way, we'll look at those and they'll be forwarded to me. So let's get started. Jason, I know this relates closely to your work with Health Equity Works. What do we need to know as some of the basic principles?
Well, first of all, thank you for including me in the panel today and for the kind introduction. It's a pleasure to be with you. I think what we need to understand first and foremost is that when people think about health, their minds typically go to healthcare. But what we know is that healthcare only contributes maybe 10 to 20% of the explanation for many of the health outcomes that we care about, including mortality. When we think about the actual health outcomes, what we're looking at is the context in which people's lives unfold. Robert Wood Johnson Foundation talks about health happening where we live, learn, work, and play. And that really is that context that we describe as the social determinants of health, which actually have an outsized impact on health outcomes. A very close to home example, when we look at the St. Louis region, you mentioned earlier the For the Sake of All report, which was a collaborative effort with colleagues here at Washington University and St. Louis University that showed, for instance, an 18-year gap in life expectancy between 63106 in North St. Louis and 63105 in the Clayton area. That the explanation for those kinds of outcomes, in order to uncover what's driving those, we have to look at what's different about 63106 and 63105. 63106, where we estimated that the life expectancy was 67 years compared to 85 in 63105, is predominantly African American, high levels of unemployment, high levels of poverty. And that is a result, the map that we see in St. Louis is a result of decades of residential segregation that was initiated by federal, state, and local policy with the aiding of private industries like banking and insurance and the real estate industry that have drawn the kinds of maps that we see of unequal access to the resources that are necessary to lead a healthy life. We also know from the work of scholars like Raj Chetty how hyper-local the ability to have economic mobility in the United States is, and also how that's tied to health outcomes. Chetty and his colleagues put out a paper in JAMA a few years ago showing a 15-year gap between the top 1% and bottom 1% of income earners for men, and a 10-year gap in life expectancy for women. So these are just some of the ways in which where you live and who you are impact our health outcomes.
Anything to add, Dean McKay or Matt?
This is Matt. I'm happy to jump in. Tom, thank you. Chancellor Martin, thank you. And good afternoon, everybody, or good morning if you're on the West Coast. So just to build on Jason's comments, I teach a course in the Brown School that is focused on health inequalities. And one of the first lectures in that course is called 61 Babies, which happens to be the number of babies that are born in St. Louis every single day. And what we do is we track what happens to 2 of those babies over the course of their lives. One of them, which leaves the hospital and gets in a car and drives to its new home in Ladue, and another baby that gets in a car and leaves the hospital and drives to its new home in Hyde Park, which is in North St. Louis. And we can use publicly available data, much like Jason has alluded to, and we can paint a pretty good picture of what that baby is likely to experience over the course of its life in terms of housing quality and neighborhood safety and exposure to environmental toxins and violence and crime and the quality of education and the availability of jobs. And when you see it that way, it is so clear and so easy to understand, if maddening, that the opportunity structure is so fundamentally different, that really explains a lot about how we end up with the health inequalities that we get. And what I think is really important about that example, just to kind of wrap it up, is that neither of those babies did anything to earn the opportunity that one gets, and none of them did anything wrong to deserve the lack of opportunity or the curse of limited opportunity. They're just babies. It's sort of an accident of birth, and it's repeated 61 times every day just in our city, and it has profound implications on people's lives. And if you didn't know the circumstances that your baby was going to be born into, there's no way that we would tolerate these sorts of inequalities and differences in the structure. And that's the way I think that we have to consider challenges like these. And that's how we're going to get to, I think, insisting upon some fundamental structural changes.
So Matt, that really is a segue for our next question. As Director of Health Communications Research Lab, what are we doing to overcome the challenges of communicating and translating science to advance health?
So I think there are at least three fundamental challenges here. And the first one actually isn't about communication or translation at all. It's about the science itself. And in public health and social work and social policy, and Dean McKay alluded to this in the video, we think and talk a lot about evidence-based approaches. In other words, solutions that have been tested scientifically. And we have a lot of confidence in evidence-based programs and solutions. We know that if we put them in place and deliver them properly, they can improve health. But the truth is that very few of our evidence-based practices are specifically designed for and tested among underserved populations. So we don't really know in every instance what works best under what circumstances for those people who need it most. And so we have to get better at that part of the science, and we have to, in our research, begin to put equity first. Secondly, we've got to partner with people who are in the community, and we need to listen to them and believe in them and trust them and understand that they know best what is likely to work in the communities that they serve, and they know what's feasible to do and what isn't feasible. And then third, I think when it comes to health equity, we're going to have to shift towards things that are harder and longer term, and I think more in the policy arena. And this is why I think the fairly recent edition of social policy at the Brown School is so important. We're going to have policy and system level changes if we want meaningful improvements in health equity. Just to give a quick example to wrap up, a couple of years ago, the Brown School hosted the state health director from Minnesota, a state that has had quite a bit of success in addressing health inequalities and health disparities. And Edward Ellinger has been in public health for 3+ decades as a leader. One of our students at the end of his talk asked him, what was the most important thing that you've done in Minnesota? Without hesitating, his answer was, it really didn't come from public health or the public health office. It came from the state legislature, and it was increasing the minimum wage in Minnesota. And so the idea is these upstream policies that can change the fundamental drivers of health are going to have these beneficial effects and that are probably more lasting.
Great.
So let me just add a word to what Matt said. And also, I think both Jason and Matt used the word equity or health equity. And I want to be sure that in our broad audience, we've defined that term. That means that your health is not predicted by your identity, your geography, the resources available. And until we get to a place where we can really invest in the solutions that uncouple that relationship. That's really what the Brown School is about, is Matt's talking about evidence-based solutions, using science to close the gap between your circumstances and improve those circumstances so your health isn't impacted.
Mary, as Dean of the Brown School, you have great insight into the work of all faculty. What are you and your colleagues working on to close the gap between health disparities as it relates to who you are and where you live?
Yeah. Well, I just want to acknowledge, so thank you, Matt. Thank you, Jason. You are two of an amazing set of colleagues within our school that are really trying to put your science, put the research tools to work to drive new solutions in our region, then across the nation and the world. And so I'll let Matt represent his work that's working with United Way data to try to make a real difference. I'll let Jason talk about the important community level interventions that he tests to really advance, community health. I do want to also acknowledge that the Brown School is an amazing institution, but we collaborate with all the other schools on the Danforth campus, as well as with the School of Medicine across the park. And so this work in order to make a difference, in order to be scalable and reach the populations that it needs to reach, you really do need collaborative models. And Matt mentioned one, collaborating with consumers, community members to come up with new solutions. So I'm going to give, because I'm a professor, I'll kind of give a mini lesson on how you think about interventions. And I'm going to introduce a kind of a framework. You could call it an ecological framework or a multi-level framework, which means our faculty at the Brown School are working at multiple levels to try to come up with new interventions, new policies, new approaches that improve health. And so what are those levels? There's a set of faculty that really concentrate on the health of individuals. And extraordinary examples of some of our colleagues, for example, Rachel Tabak and Deborah Hare-Joshu, they are partnering with a nonprofit organization, Parents as Teachers, to literally house to house, home to home, really work in an evidence-based way to help mothers and their babies be healthy and well. And there's a lot of information that you can learn about from the Brown School kind of profiles around what that work looks like. There's certainly a lot of work at the community level. I think about our colleague Vetta Thompson, who is really investing in community health workers. Jason does this work as well. Really new workforce that can reach out. And this is going to be more important than ever, that we're able to reach out to all communities as things like a COVID vaccine becomes available. And there's a lot of reasons why we'll see gaps in health disparities in the current situation magnified by our crisis. So there's a lot of work at the community level. I could mention our colleague Sean Joe, who is focusing very intensely on the outcomes, the health outcomes of young Black men in our region through a project called Homegrown STL. And then finally, Matt mentioned and talked about social welfare policy, health policy. We have amazing scholars that are really using advanced methods to help policymakers, instead of studying changes that they want to make over a 5 or a 10-year course of action, using available data to make predictions, that then evidence-based prediction that can guide some of the policy solutions, whether that be social distancing, how we're responding to our current crisis, how might Medicaid expansion close the gap in some of these health disparities that we're seeing. And so I'm just really proud of our colleagues. They're not all the same. They're working at different levels, but they're working at all parts of the problem. And I really believe that science is really going to lead to a new set of possibilities. And I would argue that there's a lot of things we can do now as we're also creating science. And so it's really been my privilege to support our colleagues at the Brown School.
Thank you, Mary. Jason, with your role at BJC and the Brown School, advancing equity is a central theme. How can the concept of health equity help advance our circumstances in the region and beyond?
I think it's a great question. And I was actually at a meeting last week where racial equity and health equity were sort of center stage. And one of the points that one of the speakers made was that when we advance equity, we're actually helping everyone. And we've seen that in our nation's history. When we increase opportunity, that increase of opportunity goes beyond just the initial group that we were hoping to benefit. So the truth is that our systems don't work for anyone in the United States. When you compare us to our other wealthy peers in the world, our health outcomes are quite poor. And it has to do with some of those policy level interventions that Matt and Mary were talking about in terms of not having a social safety net, not having the kinds of equal access to high quality education, to affordable housing. And when you look at the amount of just raw dollars that we spend on social services versus healthcare in the United States, for every dollar we spend on healthcare, we spend about 57 cents on social services compared to the $2 that our wealthy peers spend. And it shows in our health outcomes. So advancing health equity and providing the kinds of resources in terms of quality education, in terms of quality housing, in terms of jobs that pay a living wage for everyone, not only closes the gaps and disparities that we see, but it actually makes us a more viable region. It makes us a more viable nation. And there's a case to be made beyond just the moral case. There's an economic and existential case to be made for the kinds of investments that we're discussing today. And quite frankly, we don't often think about that when we think about health. We think with some justification about the 18% of GDP that we spend on healthcare. But in order for us to have better health outcomes, we have to take care of entire people and entire families and entire communities in ways that support and sustain their health.
Fascinating. I think if I shift to looking forward, and in particular, Pfizer's been in the news a lot lately for vaccination, and in particular, the groundbreaking research that's been done right here in St. Louis. And I want to relate to that, Matt, to some of your work in relationship to widespread COVID vaccinations. And how does what we've been talking about inform our efforts and communicate and distribute the vaccine?
Yeah, great. So let's think about COVID from through kind of an equity lens. COVID is not killing all Americans equally. It's killing poor and minority Americans at a much higher rate. And the government, to its credit, I think has made it very clear that we don't want that equity to continue over into the vaccination process. We want to vaccinate all Americans, but we want to prioritize those that are at highest risk. It's often the case when there's any new innovation, and I think a vaccine would qualify, that that when you introduce that into a system, it tends to benefit the haves more than the have-nots, or at least faster. And so it tends to exacerbate inequalities. And we really want to avoid that in this case. That's not going to be easy, in part because there's a lot of mistrust in a lot of communities. And that mistrust is mistrust of medicine, mistrust of healthcare, mistrust of science and research, mistrust of government. And you know, a new vaccine happens to check all of those boxes. And so there will be a lot of skepticism. And frankly, that mistrust is entirely justified. So just as an example, Black Americans remember the Tuskegee syphilis study, where Black men with syphilis were left untreated and monitored to see just how severe the brain damage and other consequences would be. And Black women were subject to experimental gynecological procedures and sterilization, without their approval. And even more recently than that, many people in our community in St. Louis and in other communities can tell you about the only way they could get healthcare was to go to the Black wards in the basements of the hospitals. So that sort of mistrust is real, and it's something that we're going to have to deal with. That's not the only challenge with COVID. I think there's a very 21st century challenge, which has to do with misinformation. And so one of the things that we are learning is that underserved populations actually are much more likely to get their health information from unreliable sources, including social media. They're more likely to be exposed to misinformation about COVID, and they're more likely to believe misinformation about COVID. So that has to be addressed too. Now, we do have, I think, one thing going for us in the vaccination challenge. COVID gives us, I believe, a big advantage over other vaccinations. So most of the time in public health, when we're trying to get the public to get vaccinated, we're promising a non-event, right? So we're telling you, do this now. It's kind of a rare outcome. It's probably not going to happen. If it happens, it maybe happens down the road sometime, but you'll be protected. COVID's different. COVID carries with it the promise that if you get this vaccination, we're one step closer to returning to our lives, our pre-COVID lives, and reclaiming some of our freedom. So I think that that's going to work in our favor. Our team is really fortunate. We were just named about 2 weeks ago to part of the national consortium of researchers that are working on vaccination equity for underserved populations. And so, Tom, I wish I had all the answers for you today, but I can tell you that this is a major focus of what our team will be working on for the next 2 to 4 years.
Yeah, and Jason, I don't know how the hospital looks at this when you look at the element of trust of who will take the vaccinations. What are some of the things you're looking to do to ensure that as many people as possible can get the vaccination to really make a difference?
I think it's going to be critical to work with community partners who already have credibility within communities. We're looking very seriously at the work that's been done through a group called Prepare STL that's been providing information about the pandemic for months now. A group that I helped to establish, the Regional Response Team, is also working on a set of messages. And really the focus has been on not trying to convince or persuade people to take this vaccine, but to provide them with the best information, to Matt's point, to correct the misinformation. And frankly, to acknowledge the legitimate reasons for distrust. The way that you build trust is being transparent and being empathic in terms of meeting people where they are, and then providing the best available evidence, the best available information for people to make their own informed choice. I don't think that an approach that sort of scolds people or tries to direct them in a particular way of behaving is going to be as effective as having those social norms among people that they know and trust, and the best available information to make an informed choice.
And I think, let me add, because transparently what I'm watching both of my colleagues do is use the very best evidence out of public health and social work around how you influence decisions. That a number of things have to line up in order to make the decision to take the vaccine or engage in protective health behaviors. That knowledge alone, without being delivered by credible sources, without being kind of surrounded by social and community norms that suggest that this is important behavior that we all engage in. And so many times, and I think, Matt, you'll come back to us with maybe a part 2 of this conversation, is what kind of support do our neighbors and we need to actually change our behavior and engage in innovation? And that's going to differ by population, by history, by experience, and we have to get even better at really being able to tailor and support our neighbors in the way that really will make a difference. Yeah.
Thanks. When I think of our discussion today, and I think of our audience, and in particular, we're learning a lot about the scholarly work and its application of what you're doing in the community. But I step back a little bit beyond just being informed and learning these things, of just kind of the call to action and what do I do? What do people in the audience do? I'm going to go with you, Mary. Can you just give us some of your thoughts that would be helpful for people in the audience of what we should be thinking about?
Okay. So given that we, our common thread over this hour is that we're connected to Washington University, and I see some of our alums from the Brown School in the chat. Thank you for writing to me, all of you as well. I think that if you think about Washington University as an anchor institution in our region, there are right now at the Brown School and then across the campuses what I'm going to call our next generation of change makers. They are studying public health. They are going to be essential workers in social work. They want to enter the policy arena, as Matt talked about. And so mentoring our undergraduate students that want to go into service, into health, investing and using your network to support those next generation of change makers, incredibly important. Opening up your opportunities for internships and work, employment is incredibly important. Many of the people on this webinar are also investing in scholarship support to open the door to the professions that are going to make a difference. And so certainly connection and relationship to our school and university, incredibly important. The next thing is that faculty like Matt and Jason, I want you to know that they are some of the hardest working colleagues I've ever seen. But they often have new ideas that they spent an enormous amount of time trying to actually convince, in Matt's case, the federal government, in Jason's case, private foundations to invest in. And they really need partners. Tom, you're one of those partners, those champions that invested in our school. But you're also, not only your philanthropic investment, but last week, you organized a set of community leaders to give the dean advice about ways that she can elevate what we're doing at the school or support our students in better ways. And so that really, the investment and partnership with faculty is so, so important so that they can do their best work. And then finally, I'm going to encourage us, and I see a little bit of this conversation in the chat, to engage in hard, challenging conversations. Are we studying disparities, or are we going to do something about it? And what are the underpinnings of those disparities? Those, you know, Jason mentioned kind of the underlying, kind of the pillars of potential racism that is holding up this situation. Matt will describe what is happening across the country in poverty impacted vulnerable populations. What is it that we need to do differently? Our own investments, our own networks, our own positionality to do better. You know, in this world. And so I think that we as humans like to be comfortable, but if you're gonna close the gap in health, and if you're gonna tackle issues related to equity, very challenging conversations around how we can work together in a different way, in a less polarized way, in a more collaborative way, are gonna be needed.
Thanks. Matt, Jason, you want to add to that at all before we jump into questions from the audience?
Just picking up on that last point, and I was going to echo what Jason said earlier about it isn't as though addressing equity just benefits some. And so, but I think it feels like that. I think at first when you hear about this concept, there is a sense that, you know, if someone is getting, you know, more opportunity and more research, then someone else must be getting less. And I think it's the challenge to all of us to assure that that isn't the case. And I would encourage, you know, everybody on this webinar, at least in your individual lives, to be open to the possibility that we can do both. And I think it's incumbent upon us to figure out a way to do that. And that is, it's not going to be easy, and it is going to require hard conversations and frankly, less talking and more listening to people who think in other ways.
I would only add that in addition to hard conversations, it's going to require strategy, and it's going to require moving upstream. We talk a lot about the upstream determinants of health as well. I'm reminded of the health impact pyramid that Dr. Tom Frieden put out a decade ago that showed that if you want to have the largest impact on population health, you have to address things like poverty and housing and education and other socioeconomic factors. And we've got to organize ourselves as anchor institutions, as citizens, around providing those kinds of opportunities for economic mobility that we know are going to drive health outcomes. I very often say a job is a health intervention. A living wage is a health intervention. A quality education is a health intervention. And we have to start thinking in more holistic ways, but also planning strategically about how do we actually get those policy wins that allow us to have the kinds of supports in community that make that kind of economic opportunity possible.
Right. So we have just under 15 minutes left of some questions. And I will tell you that we've had a tremendous amount of questions that have been presented to us, some during our session and others previously. And so we'll hopefully get to as many as we can. And so with that, I'll start this question. How can digital health products, solutions, help address the social determinants of health? Matt, would you like to answer that one?
Well, this won't be a particularly comprehensive answer, but I have at least one thought about this. I think public health agencies are like a lot of other organizations in that they are really good about thinking of what they should be doing more of, but they're not nearly as good about thinking about what they should do less of. And that's where I think technology could help us here by helping us do less more efficiently to free up some resources. So let me give you an example from our current work. Our team, one of the things that we do is we help low-income smokers to quit. And in a project that we have going on right now in 7 or 8 states, we're asking people about the sorts of help that they would like to have. And what's really interesting to us, and we haven't necessarily seen this before, is they don't really want to talk to live people. They don't want to talk to people on the phone. They don't want a coach. They don't want to go to group classes. What they do want is just in time, as needed assistance when it crops up. They're interested in apps that would help track their behavior and give them feedback. They're interested in things like that. So if we rethink, and this is already happening, it's been forced upon us with COVID and telehealth. But if we rethink how some health services are delivered, whether we can do it more efficiently without compromising effectiveness, then I think there's at least the opportunity that we could allocate resources differently, and that we could make a greater investment in some of the structural and policy interventions that Jason and Mary are talking about. So I think that's one way that these kind of digital solutions might benefit us.
Thank you. So one of the biggest challenges is the inconsistent application of clinical best practices. How does the medical profession and its educational institutions overcome the lack of consistency? And Dean McKay, I know you spent many years at the Mount Sinai School of Medicine. I'd like you to start with that one.
Well, let me broaden the kind of question just a little bit, Tom, to think about how can we think about clinical practice in social work, is it practice in public health, practice in medicine? How do we think about delivering best practices? And so the Brown School is really known for evidence-based practice models, testing those models, and then doing another part of the science called dissemination and implementation science, right? And what does D&I, or dissemination and implementation science, means? It means that when you have a new practice, when you have a new approach, human beings that are going to implement that approach need support. They need training. They need to kind of figure out how that new innovation fits within how they practice. Do they have the time to implement it? Do they have the knowledge and skill and expertise? And then also, is there a fit with the new practice and who they're trying to serve? And as Matt said, many of the practices that I'll call them first generation evidence-based practices were not tested with culturally and racially diverse groups, were not necessarily really developed in partnership with communities that perhaps need them the most. And so I think that there's a lot of work that we need to do around collaborating with practitioners to integrate better solutions and to really follow both an evidence-based approach, but also what Matt said, some of the approaches need much more collaboration and tailoring. And so I think it's going to be a lot of work because our systems are set up to achieve the exact outcomes they're achieving. And so even with some new innovations or new practices, even if those are introduced in a hospital, Jason, you're going to introduce some in the hospital and the community, they're going to need some real collaboration and real strategy around how those best practices get implemented and tailored to the right population. So there's a lot of work to do in this space, and we have some of the best dissemination and implementation scientists at the Brown School really working on how you support, consistent better application of best practices.
Yeah, and another question as it relates to this is what interventions can be deployed to those in disadvantaged zip codes? And how should we be supporting these communities? And Jason, I'll ask you that question.
Well, I think this goes back to what Mary was talking about in terms of an ecological model and multiple levels of intervention. So there are certainly interventions that we need to have at the individual level. The individual family that is facing food insecurity, that's facing transportation barriers, that needs sustainable employment or affordable housing, and really understanding to the people on the ground and tailoring our solutions to that lived experience rather than coming in with our solution and asking those families to conform to the solution. It has to work in the reverse from what we typically do. But we also have to, and Mary knows that I've said this before, we're not going to social service our way out of the disparities that we see. Social services alone are not going to change the contexts in communities. So we have to find economic engines within neighborhoods that are reliable enough and pathways to employment, pathways to wealth building and ownership, pathways to business creation that can sustain communities for the long term so that people have access to living wage jobs. And that's really the work of an entire community. That's not just the work of solving the problem at the level of the individual or that individual family. It's about creating and building places that sustain health, whether that's housing or retail or quality schools and affordable and access to transportation, but also, the more basic economic bedrocks of quality jobs, business opportunities, and opportunities to build wealth. So we've got to be able to walk and chew gum, and all of that has to be supported by a policy ecosystem that creates those incentive structures and, quite frankly, the funding to make investments in parts of our region and parts of our nation that have been left behind for far too long.
Just if I can just build upon that, I think it's it isn't an either or. Clearly, what's missing right now is really meaningful progress on the structural policy front. I think that's absolutely true. But that doesn't mean that we don't also need a functioning social service safety net. And frankly, we need a great deal of modernization in that space as well. And just to make this very concrete, if I'm a person struggling economically and I'm trying to feed my family and keep them housed, it's not that helpful to me for you to say, hey, we're working on this minimum wage policy in Jefferson City, and hopefully a couple of years from now it might come up. So we have to have a system that responds to urgent needs to literally save people's lives. And I think one of the things that we can do in that space is to provide information in an era of big data that can at least help communities make data-based informed decisions about resource allocation to help them frankly make hard decisions. But what are the neighborhoods that are most effective, and what are the issues that they're struggling with? And if we've got more than enough food assistance, but we don't have any assistance for people who are having a hard time paying the rent, should we be thinking differently about this? And what might that look like? So I think there's a lot of progress we can make in that regard. This is one of the areas, I think, Mary, you were alluding to this before kindly. Our team at the Health Communication Research Laboratory, under the amazing leadership of Rachel Garg and Balaji Gola, have created the nation's largest tracking system of social needs. So when somebody in your community is looking for food, or they're looking for quality, affordable healthcare, and they call a helpline, we're able to capture that. And we know when they needed it, to the day, and we know what zip code they live in. And we can use that information to help inform community priority setting and resource allocation. And it's actually been unbelievably helpful in understanding the social impact of COVID on a day-to-day basis across the US.
Yeah, Tom, if I could put this kind of in just a kind of a larger lens, my colleagues are talking about, really kind of mapping on, what is the investment that we're making in the root causes of this disparity in these gaps? And so those are policy, those are infrastructure, those are, kind of closed access to opportunities that Jason has really more eloquently talked about than I. And Matt, though, was talking about that if you've had harmful experiences, if you've been burdened, you also need assistance. And I can't do the history of social welfare on a webinar, but I can tell you that by design, social services are meant to kind of be funded at a level that almost gets there, but loses money every time a social service organization opens their door, right? And that had to do with our real ambivalence about how do we care for our neighbors and our people that experience poverty, people that were like us and not like us. And so how to kind of think about, Matt has amazingly rich data about where our social sector that works on the consequence side is performing adequately and where there's a really big gap. And those are a set of places that we want to invest in, but we don't want to invest in it so that we never get to the root causes, or then there'll be more and more, in my case, kids and families that have to go get those services. And so I think that there's some real opportunity to partner with both these colleagues and so many others to think about what are our investments and how they really pay off.
We had a typed in question, thank you, Mary, that said, since the US Census helps determine public health services, how might the 2020 census impact health based on who we are and where we live? Any of our panelists can answer.
Well, I'll start while my colleagues are formulating this answer. So I think if this recent crisis has not shown us sufficiently that our investment in the public's health and in what Jason calls downstream determinants, our investment in prevention and early intervention has been woefully inadequate. And our preparedness for a public health emergency in an era of misinformation and lack of investment, the consequences of that should be pretty clear based on what we're experiencing. So I think the census is one way that we invest in public health, but I do think, backing up, we need a whole other new day of really thinking about what is our investment in public health, in community health, and that is different than healthcare when you're already in pretty bad shape. And then in terms of census, it really does matter about who responds to the census and who does not. And I know that the Brown School has had a number of efforts in collaboration with lots of our community collaborators and organizations to really try to get the percentage of respondents up in our region. But those do differ by zip code, by resources, by trust and mistrust. And inherently, there'll be an under-resource in probably the communities that need it the most because of the lower participation rates. But there was also a lot of work done, and I'm really grateful for the collaborations that we've had in the school. Yeah.
We just have a minute left if Matt or Jason would like to add to anything Mary said.
I would just amplify the note about undercounting in the very areas that we know are underserved, and that sort of systematically disadvantages those parts of our region and other similar metropolitan areas. So it really is it's a challenge, but there was also heroic efforts made in the middle of a pandemic to try and get that count up. So grateful to all the groups that were part of that.
That's right.
Yeah, and let me just say, in a way, I apologize, but somehow we have to figure how the conversations continue, because there have been numerous questions that we're not able to get to, And I just want to say that it's been a privilege sharing this virtual stage with Dean McKay, Matt Kreuter, and Jason Purnell. And with that, I'd like to turn it back over to our Chancellor, Martin.
Great. Well, I too would like to thank all three of our panelists, Mary McKay, Matt Kreuter, and Jason Purnell. Thank you for sharing your insight and expertise with us today. The challenge of eliminating health disparities is quite daunting, but this is exactly why the Brown School houses programs in social work, public health, and social policy. The greatest issues require multidisciplinary collaboration and the type of academic leadership and thinking that we've just seen demonstrated. I'd also like to thank our moderator, Tom Hillman, for leading an excellent conversation. Tom, as I shared at the beginning of today's program, we could not be more grateful for the many ways you and Jennifer enrich the Washington University community. Thank you for your continued leadership.